Okay, now this is very high yield case. So if someone present with a blood pressure, high blood pressure, how do you know that high blood pressure is if the diastolic blood pressure above what?
110.
Yeah, close 120, yeah, something like
110.
110, 120, yeah. And then they have non-localizing like they have nausea, vomiting,
Mm.
confusion, okay, non-localizing neurologic signs. Okay, any end organ damage, like for example, also dyspnea they have because they can have pulmonary edema. Okay,
Mm.
so the first thing you do head CT. Okay, to rule
Mm.
out stroke, and then you treat for hypertension, which is nitroprusside. Okay, so that's in a summary. Okay, just to give you.
Mm.
Now, emergency hypertensive emergency. What could have? It can have those conditions. Okay, hypertension emergency. It can cause retinal hemorrhage, can cause papal edema, it can cause hypertension encephalopathy, which is by confusion, it can cause stroke, it can cause malignant nephrosclerosis. Okay, so the diagnosis is pretty clear, there's not much differential, but it's about complications. Okay,
Mm.
so how do you approach hypertensive emergency? Okay, as we said, the first thing, rule out stroke by head CT, rule out stroke,
Mhm.
and then you want to lower blood pressure to 100, okay, to 105 over 2 to 6 hours. Okay, so slowly, you don't lower it rapidly.
Mm.
And then you give IV nitroprusside. That's the first line. How about what is the second line? If we don't want to, just to keep in mind, what is the second line for emergency hypertension?
Hydrol
Hmm?
Hydralazine. Hydralazine.
Hydralazine for pregnant females.
Okay.
And you give labetalol, IV labetalol, nicardipine. It's I prefer that you order IV labetalol so that you switch it to PO labetalol when you're done, when the
Mm.
things are going okay. And then where do you put this patient?
I see you.
ICU, right? And then you want to order arterial line for blood
Okay.
pressure management. That's an important thing. Okay.
Mhm.
How about after 25% drop in the blood pressure? What do you do?
Monitor.
Now you don't need the ICU, so you transfer to inpatient. Okay. Discontinue the arterial line. Okay. Switch
Mhm.
IV to PO, labetalol or whatever antihypertensive. Okay.
Mhm.
Now once blood pressure under control, what do you do?
Cancel them.
Yeah, excellent. Discharge home. You do lipid profile and you counsel him. What do you counsel? You counsel medication compliance. Okay. Smoking cessation.
Yeah.
Exercise.
Mhm.
Okay. Alcohol intake. Counsel him on that. And then you want to counsel him on low salt diet. Okay. So that's
Mhm.
the most important thing. Now, how do you the things that you do for monitoring? Because you know this is the newest thing that you do. You do arterial line,
Mhm.
okay, pulse ox, and cardiac monitor. That's an important thing.
Mhm.
Location, ICU, ER, ICU, and then to the ward. And then the timing, you do emergency monitoring as soon as possible.
Mhm.
ER orders first, and then you do CT after physical exam immediately. Okay,
Mm-hmm.
and then you do medication, labetalol, IV, antihypertensive, immediately after CT. So
Mm.
those are the most important thing that they take care of. Like that's the most important thing that's gonna affect your score. So in a summary, patient present with high blood pressure, diastolic blood pressure is high.
What's the systolic?
Hmm?
What would be the high systolic?
If it's more than 200, 220, that's really high. Yeah. So the first thing you do, head CT. First thing you do, cardiac monitor,
Mm-hmm.
pulse pulse oximetry, arterial line. Not the
Mm-hmm.
arterial line initially, but the first pulse ox cardiac monitor, and then you do head CT, and then you
Mm-hmm.
give nitroprusside IV or IV labetalol, and
Okay.
then you transfer to ICU. You do arterial line now.
Mm-hmm.
Okay. Once you drop in blood pressure, you transfer to the inpatient. Discontinue arterial
Mm-hmm.
line. Switch to PO labetalol. Order lipid profile and counsel. Okay. And that's this summary for emergency hypertension.